there are no other questions, we'll move on to the final phase of today's activities. We carved out an hour for an open discussion session. And while you type in your questions to the chat room, I'd like to ask Dr. Plotkin to spend a few minutes to talk about the clinic network in the US.
Great, thank you so much. Let's see, you can hear me, right?
Yes.
Great, okay. Well, I want to highlight the work that a large number of people have done to try to elevate the status of NF care in the United States. More than 15 years ago, the Children's Tumor Foundation initiated a program of NF clinic networks that would involve clinics that had expertise in caring for individuals with NF1, NF2, and schwannomatosis. It was a long-term project that started small and has grown over time. Currently, more than 65 clinics in the United States have applied for and received approval to be part of the NF Clinic Network. These clinics they're partly coordinated through the Clinical Care Advisory Board of the Children's Tumor Foundation. And on this board includes members of the Children's Tumor Foundation, as well as a number of clinicians, such as myself. I help lead the CCAB, as well as patient representatives. And the goal of this clinic network has been to, as I said, improve the care of patients with NF in the United States. And we're starting to engage in some new projects that we believe are best answered in this setting. For example, we recently published some information looking at the effect of COVID-19 on the practice of NF neurofibromatosis clinicians and how that's changed. We're trying to extend that work, and Dr. Blakely is a big part of this, to try to get access to some of the databases to help us understand outcomes for patients who've had COVID-19. We're also trying to move forward a consensus on what represents quality care for patients with NF, and this type of work is really only possible with a large distributed network. So with that, I think if Patrice, would you like me to continue, or is that the kind of level of detail that's appropriate with our time remaining? So happy to answer.
Sure. Let's see if anybody has any questions. They want to know anything about running a clinic. We're happy to.
Yeah. And I should add that one of the goals of this, of course, is to share expertise across clinics. No one clinic can be the best at everything, of course, and it's a system where we're trying to grow clinical care, through mentorship. And just this week, we had the launch of a new program that's going to be monthly clinical conferences that we hope to expand eventually, where, much like we did this afternoon with 3 cases, use this approach of case-based learning to highlight some real experts like we heard today and how they think about cases as a way of trying to improve NF care in the US and worldwide. Questions? Let me see if I can. Nothing yet.
Miss Lynn, I see one in Spanish. You just put yourself on mute.
Let me see. Okay. Sí, yo veo preguntas, pero de la clínica estoy mirando. No vi la de la, será, déjame ver. No, de clínica no hay ninguna pregunta hasta ahora. Sí. Creo que tengo unas preguntas ya para la parte, no sé si el doctor Plotkin quiere decir algo más con respecto a la clínica, pero tengo aquí otras preguntas que han entrado que son clínicas, de casos y preguntas de NF. ¿Está bien? Gracias, doctor Plotkin.
Thank you.
Thank you. Una pregunta creo que para el doctor Carlos Romo, algo es sencillo, pero creo que es un problema que muchos adultos presentan. ¿Algún tratamiento para la rasquiña en la piel? Del doctor Jaime Valcárcel.
Rasquiña, tengo que pedir que me aclaren. Eso es en
Oh,
México.
rasquiña, sí.
Prurito.
Prurito. Sí.
Bueno, una idea por la que se cree que los neurofibromas cutáneos causan prurito o comezones porque la liberación de histamina, pero interesantemente los antihistamínicos tienden a no ayudar mucho. El ketotifeno puede ser utilizado, pero no es 100% benéfico y tiene efectos secundarios como adormecimiento o drowsiness. Entonces tampoco no lo usamos frecuentemente. No hay grandes, a veces gabapentin, tratamientos como gabapentina o pregabalina pueden ayudar, que se utilizan para dolor neuropático en disminuir la rasquiña.
Gracias, doctor. Sí, creo que algunos adultos sí se quejan y, bueno, dejémoslo ahí. Tengo una pregunta aquí, una
Could I
doctora
add quickly,
que
just
pregunta.
to add to Dr. Romo's comments? I agree that the antihistamines are rarely helpful and have side effects. Every now and again, the itchiness is really a neuropathy. It's abnormal nerve firing. And sometimes things like gabapentin can be very helpful, particularly if given at night so that you can experience the drowsiness at night. But what's really curious to me is that the itchiness seems to come and go. And so for people who say they don't want to stay on medications, which I certainly understand, we can often get away with gabapentin for maybe 6 weeks, and then that will keep things calm for a while. It doesn't work every time, but we struggle with these cutaneous neurofibromas, like what Dr. Romo was saying, understanding what aspect of the tumor is causing the itchiness. For the aspects that are caused by, for the tumors where the itchiness is caused by nerve, something like gabapentin can be helpful.
Gracias, doctor Blakely, y gracias, doctor Romo. Esta pregunta, ¿cada cuánto tiempo es sugerible hacer examen de tomografía a un paciente de 6 años que gracias a Dios no convulsiona, presenta manchas café con leche y 8 neurofibromas pequeños? Eso, doctor Blakely.
Thank you. So a couple things. In our center, there is no guideline, but in our center, we do not do surveillance and imaging of any kind if there's nothing on exam or by history to suggest a need for surveillance. So we are exploring whether we should be changing our opinions about this. But if we were to do surveillance, we would use whole body MRI, which is not available everywhere in the way we use it, which is a single coil that can image from tip of head to mid calf in about an hour and 15 minutes, one sequence. But it gives a very good view of nerve sheath tumors and multiple other abnormalities. Again, we are not using that for surveillance yet, but as more natural history data is available about plexiform neurofibromas, we are thinking about it and debating it more for children who are old enough that they would not require anesthesia for the MRI, and old enough where we think their natural history, their full expression would be realized. So maybe somewhere between 10 and 15. In general, we don't use CT. We don't use CT for a couple of reasons. It's not very accurate at nerve sheath tumors. It does have associated radiation. So if we're getting a CT, it's because we're either looking for a gist in the abdomen or we're looking for something bony. So I guess I would say in a 6-year-old who has the mild skin manifestations you're mentioning, I wouldn't be getting any imaging. I'd be seeing them in clinic once a year. And if I had a concern, I would start with MRI. Dr. Romo, Dr. Wiedemann, Dr. Plotkin, any other thoughts?
I agree that physical exam and a close examination is a good way to start, and only if there's seizures or something else, MRI would be the preferred imaging modality over CT scan.
I agree, Jayshree. I have nothing to add. Agree with you and with Carlos.
I see a question about clinics from Rodrigo Mejia. What is the typical team composition for a network clinic? Is there a minimum number of patients a clinic should see to be considered as CTF clinic network candidate? What resources are available for network clinics from CTF?
Those are very good questions. So the first one was, what is the composition of the clinics? And we recognize that each clinic is slightly different based on their institution. So for example, some clinics have a pediatric neurologist leading the team. Sometimes it's a neuro-oncologist. We've had neurosurgeons leading clinics and so forth. So we don't believe there's a one size fits all. What we do require is that adequate multidisciplinary teams are available. And we ask for the applicants to specify who's on their team. And that encourages them to reach out. If you don't normally work with an ENT surgeon for, let's say, an NF2 patient, you have to establish that relationship and have that person agree to be part of your team. If you don't have a geneticist you work with, that's appropriate, of course. So it's not mandated specifically, but we have a lot of areas where we encourage you to have these multidisciplinary collaborations. We encourage clinics to have transition plans between pediatric and adult care and how that's accomplished. In terms of the number of patients seen, we don't have absolute guidelines, but this is an important part of it, because study after study has shown that volume of patients is correlated with clinical outcome. That is, if you're a surgeon and you do gallbladder surgeries and you do 500 in a year, you're probably more skilled than somebody who does it once a year. And that's not a comment about the surgeon herself or himself, but really a comment about how teams work together in high volume situations. So there are numbers. I can't quote to you today unless Patrice can remember offhand, but the number of patients is important. And then finally, in terms of what CTF resources can be provided, we recognize that CTF is not going to fund every clinic around the United States. It's not a realistic venture. What CTF does is strategically apply funds to improve the capacity of clinics by supplying support for individuals to come to the annual meeting, which is our primary educational meeting of the year, and also to support other conferences, annual meetings between the clinic and patients, to have these forums where patients are allowed to be educated and meet their clinicians. Those are two really important aspects of being within the community. And then there are maybe occasional other things that get supported, but I would say those are the two key ones. Patrice, do you have anything to add to that in terms of what CTF supports in terms of the, or Dr. Bacher?
Go ahead, Annette. I'll let you answer that.
I'm sorry, I was struggling with my error. So yes, indeed. So now with, of course, with the whole COVID situation, people cannot really travel. So now we're also providing some virtual trainings like this morning, and we're also rolling out master classes in Europe for people to be trained in NF, and so that we can start really building out a network for NF clinics worldwide. Now, what we have done, just to give a little bit of a spiel of what we did in Europe. In Europe, the first thing we did before we even started thinking about a clinic network, we first fundraised. And then when we had some funding available, because you cannot build a clinic network just out of the blue. So once we had secured some funding, which we have now for 3 years, then we started assembling ideas from the clinicians to say, how can we build a clinic network? What would be useful for you? What is potentially translatable from the US to Europe and what is not translatable? But we really don't want to waste your guys' time starting to dream about projects that we won't be able to execute on. So that is that's kind of the strategy that we used in Europe.
Muy bien, gracias, Annette, Dr. Plotkin. Tengo una pregunta, se me hace interesante. ¿A qué edad se completa la penetrancia del NF1, del gene de la NF1? Creo que para el que quiera contestarla. Si no la puedo contestar yo, como genetista. La forma es muy interesante pregunta, porque definitivamente NF1 es una condición dominante y generalmente penetrante, full penetrance, completamente. Así que una persona que tenga experiencia viendo familias con neurofibromatosis puede diagnosticar clínicamente si algún adulto tiene neurofibromatosis. Le verá las manchas, le ve las pecas, le busca los nódulos de Lisch y le ve también seguramente los neurofibromas. Pero en mi práctica yo podría decir algo y no creo que esté escrito, pues yo creo que la penetrancia con neurofibromatosis tipo 1, y me gustaría oír a mis colegas, podemos determinarla hacia los 2 años. ¿Por qué lo digo eso? Cuando tengo una pareja que uno de los dos tiene neurofibromatosis y nace un bebé que no se hizo ningún diagnóstico prenatal, si a los 2 años ese bebé no ha presentado ninguna manchita café con leche, estoy hablando de neurofibromatosis tipo 1, si a los 2 años ese niño no ha presentado ninguna manchita café con leche, me atrevo a decirle a las familias que estoy 98%, 99% segura que el niño no heredó el cromosoma 17 con la variante del NF1. Es mi opinión personal. No revisé este tema antes de saber qué está escrito, pero me llama la atención oír qué opinan ustedes. Se me hace una pregunta muy, muy buena, porque hasta qué momento podemos sospechar si alguien heredó o no el gen. Claro, hoy tenemos estudios genéticos, pues ustedes vieron cómo en nuestros países, en Colombia, en Perú, en todas, no es fácil hacer un examen del ADN. Así que quisiera oír, esa es mi respuesta, quisiera oír qué dicen doctor Botero, que está mi genetista, el doctor Romer, la doctora Blakely. Me llamaría la atención oír cuál es su respuesta. Excelente pregunta, por lo menos para una genetista. Gracias.
Estoy de acuerdo con Dr. Bauer en que los 2 años suele ser un momento clave y normalmente si no encontramos ningún hallazgo clínico para ese momento ni tampoco documentamos una variante patogénica en NF1, podemos con mucha confianza descartar el diagnóstico. También hay muchos pacientes que tenemos que tienen solo manchas café con leche y podemos después pensar en un Leges si no tienen ninguna otra manifestación, pero estoy de acuerdo en que ese concepto de fulfill la penetrancia es interesante y normalmente a los 2 años si un paciente no tiene ninguna manifestación observable o algún otro signo que lo indique, pues es muy probable que no tenga NF.
¿Alguien más quiere hacer un comentario? Y si no, vamos a seguir. ¿Qué otra pregunta
I'll just
tenemos?
agree that assuming we
otra
know
pregunta
that one of the parents has it, then that's a helpful landmark. I also hedge my bets and say you have to keep coming to clinic for me to see you, because there are the very rare, even though it's the exact same gene that has the alteration inherited, the manifestations can be so varied that sometimes we will be surprised and see something later. But I also will admit that I rely heavily on genetic testing. So, but I agree, it's very reassuring. And I will say I'm an adult neuro-oncologist, so I think I have the easy end of things, because by the time people come to me, I get to say, well, you haven't had optic pathway glioma, you're not going to. You haven't had major plexiform neurofibroma of the face, you're not going to. And so we get to run off a lot of things that people aren't going to have because they haven't developed them yet, whereas the geneticists and pediatric neurologists have it harder, I think.
Gracias, doctor Blakely. Sí, esto es en el escenario donde uno de los padres tiene NF. Muchos de estos son pacientes, por ejemplo, que han venido a verme a mí. Uno de ellos es mi paciente y quedan embarazados o que es padre del bebé y quieren saber hasta qué punto puedo sentirme como... Y estoy completamente de acuerdo con usted. Estos niños los seguimos viendo, por lo menos para estar seguro que no aparezca algún hallazgo, pero casi siempre si manchitas café con leche no se han presentado hacia los 2 años, yo personalmente me puedo sentir bastante segura y tranquilizo a las familias. Y claro, hoy en día tengo la fortuna de empezar a hacer estudios del ADN. Gracias. Doctor Botero, ¿quieres decir alguna otra cosa?
Quizá en relación con lo que decía Dr. Blakely, los únicos otros casos donde estaría más vigilante y quisiera hacer un poco de seguimientos podrían ser familias con mosaic, con casos en mosaico, donde lo sospeche mosaico y quiera asegurarme eventualmente que el niño o la niña que estoy viendo de pronto no muestra manifestaciones por esa razón. Entonces quizá podría pensar en seguirlo un poco más adelante en la infancia, hasta los 8 años quizá, pero creo que estoy en general de acuerdo con lo que se ha dicho.
Perfecto, gracias, doctor Botero. Hay una pregunta, de pronto siguiendo en la misma línea, ¿qué tan frecuente vemos mosaicismo gonadal, tanto en NF1 o NF2? ¿Y de qué forma impactaría esto la consejería genética? No sé si, doctor Botero, ¿quiere usted contestar? O...
Seguro, creo que podemos todos poner nuestro input. Pienso que es efectivamente un reto en asesoría genética. La incidencia de mosaicismo gonadal es alta en NF1. Creo que está claro para todos los que estamos aquí que NF1 en sí mismo es una condición complicada, donde hay muchas variables a tener en cuenta. Y en el contexto de los casos en mosaico, pues normalmente es difícil identificar variantes, es difícil ofrecer alternativas como por ejemplo diagnóstico prenatal de tipo no invasivo, en parejas, en personas afectadas que quieran concebir. Entonces, esas tasas de mosaicismo son altas y en ese sentido hay que ser muy, muy cauto con los porcentajes y hablar pues desde lo que está en la población general del 1% hasta el 50% y seguir a los pacientes en la manera de lo posible. Hacer uso de la historia familiar, mirar muy de cerca la historia familiar para poder identificar los casos que sean de nuevo y los que se estén heredando y así ver patrones que puedan llevarnos a la idea de que estemos ante un mosaicismo, bien sea germinal o un caso en mosaico.
Gracias. ¿Alguien más quiere hacer un comentario? Estoy viendo que otras preguntas están entrando. Hay unas que están en inglés. Patrice, I don't know if you want to read, si los quiere leer. Ok, una pregunta. ¿Podría brigatinib potencialmente ser usado en pacientes con NF2 mosaico? De pronto, Dr. Plotkin.
Yes, I don't think, we believe, we hope that brigatinib will be effective in treating tumors driven by NF2 loss. And the concept of mosaicism is one that applies to the entire person, not to the tumor. That is, although the entire person all the cells may not be affected by the NF2 pathogenic variant, wherever there is a tumor, that is a part of the body that's affected by NF2 loss. And therefore, the tumors would represent tumors driven by NF2 loss, and we hope sensitive to brigatinib and the other drugs that we hope to study. So I would say that the status as mosaic or not mosaic does not affect our thinking in terms of clinical trials, at least not at this point.
Gracias, doctor Plotkin. Tengo otra pregunta aquí, nuevo. Una niña de 3 años diagnosticada con NF1 tiene gliomas bilaterales en los nervios ópticos. Hasta el momento son caracterizados como benignos, aunque tiene una ubicación maligna. ¿Qué posibilidad hay de que se conviertan en gliomas malignos? Es la primera pregunta. Y segunda, ¿pueden los MEK inhibitors ayudar a que no se conviertan en malignidad? Dr. Blakely.
Yeah, so there are two, maybe the first distinction is malignant defined by histopathology. In other words, additional mutations are acquired like in P53 or P10 that would turn a tumor from the optic pathway, which is almost always a pilocytic astrocytoma, a grade 1 glioma. It would turn it from that into an infiltrating low-grade glioma and then ultimately a high-grade glioma. That does happen, but thankfully it's incredibly rare, incredibly rare. I'm going to come back to that in a minute. The much more common scenario is that the histologically benign pilocytic astrocytomas progress to cause really devastating clinical manifestations, such as blindness or changes in the pituitary gland that can result in precocious puberty or other endocrine dysfunction that can affect bone development. And so the first thing we monitor is vision. And the most important evaluation for a child with NF1 with optic pathway glioma is the ophthalmologist. Like Dr. Kwok was saying with our NF2 patients where vision is threatened. And they should be established with an ophthalmologist and ideally see the same ophthalmologist. If we're really lucky, it's a neuro-ophthalmologist, but we don't need to be greedy, just any ophthalmologist. That ophthalmologist should know that child because of course, ophthalmology is a tough exam and children have variable performance visit to visit. And one of the reasons we recommend frequent visits is to account for that variability. But if there is a drop in more than 2 lines on the Snellen scale, or if there's loss of color vision, or if there's access to an optic coherence tomography, and there's loss of thickness of a neuronal layer, those would all be indications to start treatment. The standard treatment today, February 2021, is a carboplatin-based regimen. In America, it's carboplatin vincristine. In Europe, they like carboplatin alone. Either one is fine. Dr. Wiedemann showed in her presentation, there are actually 2 studies opening that are looking at selumetinib as first line for optic pathway glioma. And we're very excited about this potential because while the carboplatin-based regimens are effective for the vast majority of children, probably 60% of children, they are very hard to tolerate and associated with long-term cognitive deficits. So selumetinib would be a better option if we could show the same efficacy. So in this child with bilateral optic pathway gliomas, my anxiety would be monitoring their vision very closely. If they had progression of their vision deficits or loss of the neuronal thickness in the optic coherence tomography, I would start treatment. In terms of malignant progression, unfortunately, we really have no idea how frequently that happens. We do take care of adult patients with transformed gliomas. They had an optic pathway glioma and it became malignant. It's unbelievably rare. I have taken care of 3 patients in my 20-year career with that situation. So typically in children who needed treatment for their optic pathway glioma, which is very few children, maybe 30% of all children with optic pathway gliomas need treatment. But in those children, I will ask for MRIs of the brain until they're in their 20s for surveillance. And then once they're in their 20s, I wean myself. The patient's fine, but I'm nervous. So I wean myself. First, I get MRI every 2 years, then every 3 years, then every 5 years to ensure there's not going to be a transformation.
Perfecto, excelente, Dr. Blakely. Aquí hay una pregunta. ¿Las manchas café olé deben protegerse del sol más que el resto de la piel? Y si es así, ¿qué tipo de protector solar se recomienda? Creo que doctor Romo, esta pregunta va para usted.
Gracias. Pienso que protegerse la piel con un protector solar es bueno en general, café olé o no café olé. Y yo también soy neurólogo, entonces de dermatología no estoy no soy un experto, pero yo pienso que algo que tenga una protección de 30 o 40 o más SPF sería suficiente y aplicarlo a todas las áreas, incluidos los oídos, el cuello, áreas que generalmente no pensamos en esas. Pero el riesgo no sé si la pregunta iba sobre el riesgo de transformación a melanoma o algo por el estilo, eso sería extremadamente raro.
Sí, me imagino. Nosotros viviendo aquí en la Florida les digo a mis pacientes, hay que cubrir a su hijo con ENEF igual que a todos sus otros hijos. Es decir, no es que vayan a tener más riesgo de malignidad o melanoma, pero
claro,
sí necesitan proteger la piel como cualquier niño que vive aquí en la Florida. Doctor, mil gracias y creo que así concluimos con la sesión de preguntas y respuestas. Creo que han quedado unas otras que estaban repetidas. Vamos a tratar de contestar estas de alguna forma por vía email. Y creo que Patricia quiere que yo en este momento quiero darles primero la gracia a nuestros presentadores, nuestros expositores por excelentes presentaciones. Yo me siento muy honrada de estar aquí, de haber participado con ustedes, nuestra audiencia, las preguntas, el interés. Me da un poco pena de que hubo un gran grupo de personas que no pudieron unirse, pero yo creo que vamos a hacerles llegar a ellos la presentación. Y lo último es que se va a mandar un cuestionario, tan pronto terminemos, estamos terminando de ver, queremos saber de dónde son ustedes los que nos han oído desde temprano esta mañana, qué preguntas tienen, qué temas, porque yo espero que este tipo de conferencias virtuales continúen y sigamos trabajando juntos, tanto con CTF como Genes Foundation. Creo que yo voy a agradecerles a todos el haber estado aquí un sábado en la mañana, pero creo que ha sido muy productivo, Dr. Blakely. Gracias por haber manejado estos casos y creo que fueron 3 casos excelentes. Y a nuestros presentadores de los casos también, la doctora Patricia, el doctor Juan y el doctor Vélez, Alberto, gracias. Creo que ha sido fantástico. Y le voy a pasar la batuta a Patrice, a ver si Patrice tiene algo o Annette, para concluir esta excelente sesión de neurofibromatosis. Gracias.
Well, I don't think I could say it any better, Dr. Bauer. Thank you to all of you. Your participation was just terrific, and you made for a fantastic program. We're truly grateful for what you do and how you share it with the community. And we will, as Dr. Bauer said, we're going to try and get this program out to everybody so that they can share in it also. And we will be sending out a survey. It might not be the second this is over. We're still putting it together, but we do want to make contact with everyone who registered and obviously everyone who was here today and who presented today. So you'll be hearing from us in the next day or so. And with that, if Annette Bacher would like to say some.
I just wanted to say thank you.
Comments.
Thank you to everybody for being here. Let us, as it was mentioned a couple of times, let's figure out if there was a technical glitch, because we will check it out. But we all know that when there is an event that we sometimes sign up for it and then don't show up, right? I'm guilty of that, and I think everybody here today. So let us check it out, but and make sure that the recordings are available for everybody who later on will regret not to have been at this fabulous day. So thank you for the speakers. Thank you for the participants. Thank you, Patrice, Simon, the whole team behind the scenes. And thanks to the Genes Foundation as well. And have a lovely Saturday afternoon and happy Rare Disease Day.
Thank you, everyone.